Welcome to this explainer. Today, we're diving into jaundice, and we're going to treat it a little differently. Instead of looking at it as this massive, confusing, endless list of diseases to memorize, we're going to approach it as a pure, elegant exercise in physiological reasoning. Too often, we get completely bogged down in the massive differential diagnosis of a jaundiced patient. But actually, if you take a step back and just understand the fixed, linear journey of bilirubin, the human body will quite literally tell you exactly where the problem is.
So picture this. A patient walks into your clinic and their skin is undeniably yellow. Now, before you've even asked a single question or drawn a drop of blood, three specific things are already broadcasting vital clues: the color of their stool, the color of their urine, and whether their sclera, the whites of their eyes, are truly yellow or perfectly clear. Nailing down these three simple details is absolutely crucial. It's your master key to localizing the diagnosis to before, within, or after the liver.
Section 1. The Master Map. Bilirubin's Journey.
To solve this whole mystery, we really have to memorize this pathway, because literally everything else follows from it. Think of it like a giant plumbing system. Step 1. Old red blood cells break down and they release unconjugated bilirubin. This unconjugated bilirubin travels straight to the liver. There, in step 2, the hepatocytes get to work and conjugate it, which basically just makes it water-soluble. Okay, step 3. This newly conjugated bilirubin is excreted into the bile and travels down the biliary tree. And finally, step 4, it hits the intestine. Here, gut bacteria convert it into stercobilinogen, which gives stool its normal brown color, and urobilinogen, which gets partly reabsorbed and gives urine its classic yellow tint. That is the entire shebang: production, conjugation, excretion, and gut transit.
Section 2. Locating the break. Jaundice basically happens whenever bilirubin backs up faster than that pathway can clear it. And what's super interesting is how perfectly our physical clues map out where the system broke. For example, prehepatic issues like hemolysis mostly leave urine and stool totally normal. Hepatic issues give you a mixed bag. But posthepatic obstructive jaundice, that is a textbook complete roadblock. If there's a physical block, like a gallstone or a tumor, that conjugated bilirubin never reaches the gut. The result? Zero stercobilinogen is formed, meaning you get pale, clay-colored stool. Plus, that water-soluble conjugated bilirubin has to go somewhere, right? It backs up into the blood, the kidneys filter it out, and boom, you get incredibly dark urine. And because bile acids are also backing up with it, they severely irritate peripheral nerves, causing intense, maddening pruritus or itching. Clinically, this type of obstructive jaundice often looks really deep, almost greenish, compared to the standard yellow of hepatic jaundice.
Section 3. Diagnostic Traps and Mimics.
Even the best physiological detectives can be fooled, so we have to watch out for mimics. The biggest one is distinguishing true jaundice from something totally benign like carotenemia. Say a patient went on a massive health kick and just ate way too many carrots or sweet potatoes. Their skin might actually turn yellow. But here's the trick. Carotenemia characteristically starts at the palms and soles, and critically, it entirely spares the sclera. If their eyes are pure white, you can spot the difference at a glance. It's a beautifully simple differentiator that'll save you from doing a massive medical workup on a vegetable overdose.
We also have to keep in mind the named exceptions to our rules. Take Dubin-Johnson syndrome. This is an autosomal recessive disorder where bilirubin just isn't excreted normally. You get conjugated hyperbilirubinemia, but the patient's liver enzymes are actually completely normal. And the real kicker? The patient experiences absolutely no itching. Pruritus is normally such a rock-solid feature of true cholestasis, so seeing it totally absent here is a massive red flag that you're dealing with this specific rare syndrome.
Section 4. Filters and Red Flags.
Once we've localized the break in our pathway, patient demographics act as incredibly powerful diagnostic filters. A young patient presenting with jaundice, that should quickly point you toward Wilson's disease or a drug-induced cause. A middle-aged woman powerfully shifts your radar toward primary biliary cholangitis, or PBC, and autoimmune hepatitis. A middle-aged man, on the other hand, should instantly raise your suspicion for pancreatic cancer or alcohol-related liver disease. Obviously, these don't rule out other things entirely, but they dramatically shift where you should start looking first.
And then we have these specific clinical pictures that you just need to recognize as a complete package. Imagine a cachectic, pale patient. They've got deep, painless jaundice, scratch marks everywhere from severe itching, and a palpable gallbladder. You really need to pay attention here. But more importantly, notice what is missing. There are no cirrhotic stigmata, no ascites, no spider nevi. That absence is a massive clue. It tells you this isn't intrinsic liver disease. This specific picture should point you strongly and urgently toward a malignant distal biliary obstruction, like cancer of the pancreatic head.
Now, here's a really vital current caveat for clinical practice in 2025. When malignancy is suspected, a lot of people immediately reach for the tumor marker CA19-9, but current oncology guidelines emphasize that CA19-9 is explicitly not specific. Simple biliary obstruction, cholangitis, or even just benign inflammation can cause this marker to shoot up. So, while an elevated level definitely supports your concern, you can never, ever rely on it to confirm malignancy all by itself.
Section 5. The final investigation. So our physiological reasoning has pointed us in the right direction. How do we definitively confirm it? Well, imaging follows a very logical progression. An abdominal ultrasound is your simple, effective first step. It's perfect for spotting a dilated common bile duct, the classic signature of an extrahepatic block. Next, if you need a detailed map of the biliary anatomy without being invasive, you step up to an MRCP. And finally, there's ERCP. This one is an absolute game changer because it's both diagnostic and therapeutic. A specialist can literally extract the blocking stone or place a stent during the exact same procedure.
If your clinical picture and initial imaging do point to a biliary tract cancer, the updated 2025 oncology guidance is incredibly strict about next steps. Coordinated specialist input isn't just a suggestion anymore. Multidisciplinary evaluation at a high-volume center is absolutely mandatory to properly assess for resectability and plan treatment.
To finish out the workup, you're going to pull standard labs tailored to your differential. You know the drill. Standard liver function tests, viral serology, autoimmune markers, and iron studies. But please, always remember to check a serum paracetamol level. It sounds basic, but paracetamol overdoses are incredibly dangerous and notoriously easy to miss if you aren't explicitly looking for them.
Section 6. The elegance of first principles.
We've followed the map from the very creation of bilirubin to its final exit, using observable clues to locate exactly where the system backed up. We've talked about MRCPs, ERCPs, and the latest 2025 oncology guidelines. But as we wrap up this explainer, I want to leave you with this thought. Despite all our modern imaging and incredibly advanced lab panels, the fundamental nature of the human body still allows us to diagnose complex obstructions using basic, unbroken physiological rules. Isn't it fascinating that in 2025, the absolute most vital step in diagnosing jaundice still relies entirely on the simple, observable physiology of a patient's stool, their urine, and a purely physical exam?